Hi, everybody. Big hugs. I miss you so much. I'm so happy to see your faces. We're really grateful to our sponsors this evening, Takeda, Novo, Diplomat, which is becoming Optum Infusion Pharmacy, and Medexus Pharma. I want to shout out a big thank you to our tech team, Chris Brewer, Eric Lowe, and Joan, who has a better handle on this than I do. So I cannot thank you enough for being able to make all of this happen for us. Again, a big thank you to our physicians, and I'm going to introduce them in a couple of minutes. And a big thank you to all of you for being here on a Thursday night or Thursday afternoon, wherever you're from. Thank you so much. We just love to see your faces. It's just awesome. Just a reminder, next Thursday on October 22nd, we will be welcoming Dr. Christina Haley and her OBGYN, Dr. Maureen Baldwin, for a session on managing menorrhagia. For everyone that's interested in coming. One of the blessings in one way about having you do this virtually is, we'd have an OBGYN with us at LadyBugs, and we'd have an hour and a half, and we could have spoken to her all day, right? And bless her, she was trying to cover from, beginning of menses to menopause within that 90 minutes. And it just, every evaluation always said, we need more time. We need more time. And I'm like, I know you need more time. So in this way, by doing it virtually, we decided to kind of split it up. So we will do Managing Menorrhagia October 22nd. And then in January, we will be continuing our LadyBugs programming as well as our rare bleeding disorder programming. And we will do another session on childbirth and birth plans for women with bleeding disorders. And then we will also have another session on sexual health and intimacy issues, which is always something that, we've tried to touch on it, and a lot of the comments were, we'd like a little bit more information on that, and I totally get it. So we're really excited that we'll be able to offer those kind of in their own 90-minute session. So Dr. Haley and Dr. Baldwin are from OHSU, which does have a women's clinic, so we're really excited to have them. Once we split into our rooms, if you put your questions in the chat, the person who's moderating the room will keep track of them. To be mindful of our speakers' time, we're going to save the questions till the end. I know everyone has a question, and we just want to make certain that our speakers who have put a lot of time and energy into their presentations have an opportunity to get through them all. And we will try to answer as many questions as possible, but please know, the moderator will be taking probably the questions that are the most pressing from the largest group of people, and we're just going to do the best that we can.
All right, so we're back to my slide. So when we talk about RBDs, so the issues that are faced with by people with hemophilia are certainly magnified in those with RBDs, right? So the problems, for example, rely on the fact that there is certainly a great delay in diagnosis, which will translate into a great morbidity, great mortality. We really don't have those many specific products or specific treatments depending on the rare bleeding disorder that we might have, and we actually need to use other ways to treat the deficiencies on the right way, but actually they're not as specific. So that implies and that signifies issues with a proper laboratory monitoring during treatment, limited resources for treatment, etc. Because we are still relatively a small number or a small community, that is going to translate into, some issues or some difficulties when we try to study our population with RBDs, because we don't have that just many patients. So it's also implying an increased cost for insurance coverage or an increased cost for even, the same facilities that translate at the end into issues with insurance, right? So nowadays, 2020, we always need to struggle with insurance companies to actually not only just recognize this diagnosis that they can present in women, but also the fact that these are diagnoses that actually deserve treatment. So I think that that's important. One of the characteristics of RBDs is the way in where they are transmitted. So as different from hemophilia, RBDs can affect, definitely affect both male and females. And actually the mechanism in where like they're transmitted is this autosomal recessive mechanism. So meaning that for a person to really express most of the symptoms typical of the particular condition, both parents need to be carriers. And that's also important when it comes to genetic counseling or when we, decide to have kids, because we see here that, the chances from two carriers to pass the disease on to a child is actually 25%. So there's 25% of chances that the child would express the disease, 25% that it's going to be normal, so having no mutations, no problems whatsoever, and 50% chance it's going to be a carrier. So meaning that we'll have the 50% of the genetic information, and of course that brings on the risk for either married another carrier or married actually what it has happened, because I have patients here that actually have two different rare bleeding disorders. I have a young lady, she is 15 with actually factor 7 and 11 deficiencies. And, that's just, sometimes the way it is. But I think it's important because we need to sort of understand that. And it's important now that we also need to pay attention to our genetics, right? Because it's always important to look for some genetic advice for, those patients that are, within reproductive age, and even like when it comes to have kids or whatever, like to maybe look for trying to identify if the mutation is present or not. RBDs in general are considered and cannot be considered as a single class of disorders. Okay, so that's also another important key point that I want you all to remember. So they're different one to another, and they're different because they can present, even though that they will have the same symptoms, but the frequency of the symptoms and the severity of the symptoms are going to be different depending on which is a specific coagulation factor or which is a specific platelet disorder that we have in front. In terms of coagulation factors, for example, here I have that there is a strong association with, for example, those patients that have fibrinogen deficiency, that have factor 13 deficiency. So meaning that the strong or weak association means that actually the low my factor level is, the more symptoms I'm going to have. So we see here with weak association, for example, a typical example of it is factor 7 deficiency. Because not just because I'm going to have a factor 7 deficiency, a factor 7 level that's actually very low, I'm also going to have a lot of symptoms. That actually is very characteristic of factor 7, as we're going to see on the next slide. The symptoms can be different, can go all the way from, some easy bruising or skin bruising, as we see here. But they can go all the way to even joint bleeding or muscle bleeding. In the case of women, for sure, menorrhagia is a big player. But what happens is that not because my level is 20 and not 60, I'm going to have more symptoms. Actually, a person with a 60% level can have way more symptoms than a person with a level of 20. And that has to be with the specific mutation that is causing the deficiency. Factor 7 is a big one because I apologize because I did not include this on this presentation, but a few years ago, LadyBugs and Chess, I believe, John, you were part of this study in where they studied the different genetic mutations in factor 7 deficient patients. And there's so many of them that we can just not really necessarily test all of them. We have the ability in the majority of places to test for the most common genetic mutation that is associated with factor 7. But on that study, for example, from, I believe, out of 15 or 16 women, they identified actually 20 plus different mutations that were causative of factor 7 deficiency. So that's actually really, really important to understand and to keep in mind. In the case of factor 11, those individuals with a factor level that are very low, less than 20%, are going to be the ones more likely to present bleeding complications. Bleeding complications include bruising, epistaxis, so nosebleeds, blood in the urine, hematuria, heavy periods, and hematomas. But what is interesting with the factor 11 deficient patients is that, yes, they might not present symptoms unless they have very low levels. But remember that my normal levels are always 50 and above, right? So that's also important. So for the majority of factors, normal means 50 to 150. So even though that those less than 20 are going to present more symptoms on a daily basis, or like more frequent symptoms, like those, for example, that might have a factor level of 48, so just minimally low, but they're exposed to either a surgery, a dental extraction, a C-section, that they have menorrhagia, they still are going to bleed, and they're still gonna have severe bleeding. So that's also important, because many times my patients, my adolescent females, my girls, they come and say, well, I have 48% factor 11, so I should be okay because it's not that far from 50%. But then when it comes to like having surgeries and going to the dentist, they need to understand that we also need to take precautions, because actually during surgeries or during those procedures, you need to have even higher numbers, higher levels of these factors. So like that is what we need to keep in mind. Not because I'm just barely there, I'm not gonna have problems. I mean, because when I really need to have way more numbers, way more levels in these factors, I'm not gonna be able to provide that to my system, to my body. And that is when the problem happens. I know that maybe that here in the audience, we also have some ladies with fibrinogen problems. Fibrinogen is actually very tricky, because as we see here, problems with fibrinogen mean that the fibrinogen can be low or non-existent, and this is the afibrinogenemia. Or fibrinogen can be present but cannot be working the right way, and this is the dysfibrinogenemia type of patients, right? And this is important because low levels of fibrinogen are going to definitely be associated with bleeding risk. As we see here, intracranial bleed, so head bleeds, joint bleeds, they're gonna have just a tendency to bleed overall. But those patients in where like they have adequate numbers of fibrinogen, but fibrinogen is not working the way it's supposed to work, then we're gonna have a constellation of symptoms. They can be bleeding, but there can also be clotting. So we need to be very, understandable of that as well, because this is gonna actually make it more tricky for the patient itself to recognize what the problem is, and even for the physician or the provider to really come up with the right treatment or the right strategy for this. And look in here, 43% of patients with fibrinogen, with dysfibrinogenemia, are going to be asymptomatic. But that doesn't mean that at some point in time, they're not going to either have a bleeding problem or a clotting problem. So that's also important to keep in mind. In the case of GT, the condition we know occurs more frequently in populations with consanguinity. So there are certain regions in the world, like Middle East, India, or France, in where this is more common than in other places. It is usually diagnosed before age 5. And again, the constellation of symptoms can be multiple. Can go excessive bruising, nosebleeds, mouth bleeding, and rarely, but it has been reported, there can be also internal bleeding, and the severity is gonna be so different from one to another, that we also need to be always in the lookout. We also need to be always, paying attention to each and every single thing that might happen on our patient's life, to prevent actually and to act on time when a bleeding episode happens. symptoms. In the case of women with RBD, the bleeding intensity is just not extremely variable, as we have seen. But most of the women with bleeding disorders or with rare bleeding disorders, they're going to start experiencing symptoms or having problems as they approach to the adolescence or they go into young adulthood, as they are at a high risk for presenting heavy periods. They're also going to have risk for increased risk for ovarian cysts, endometriosis, endometrial hyperplasia, and definitely goes without saying that during pregnancy or childbirth, women are going to be just at a higher risk for presenting postpartum bleeding. They're also going to be at risk for presenting miscarriages. And all these symptoms at the end of the day, what they do is, again, as we see here, they're going to impact the quality of life and the employment, or the capacity to have, quotation marks, a regular normal life or a regular performance at work because of all these problems, right? So that's why there is a lot of prevalence of missing work days and missing school days in women with bleeding disorders. So if we see at this table, we see that there is a constellation of symptoms, but what is also important, and I want to point this out today, is that women with rare bleeding disorders are also going to present with symptoms that we tend to believe that are just as specific of hemophilia, as for example, joint bleeding and muscle bleeding, right? So those are symptoms that we tend to say, okay, so they're usually not that typical or on factor 11, on GTs, on 7, whatever it is. But let's see here on this study that is a bit old, is in 2011 was published, but we still see here that the prevalence, the percentage is quite considerable, 16% for joint bleeds and close to 9% for muscle bleed. So we definitely need to be aware of this. And look at the symptoms that are more frequently encountered, as we saw, are all those that are mucocutaneous. So heavy bleeding from periods, bleeding during pregnancy as well, and of course the nosebleeds are very prevalent as well in our population. If we just try to focus into heavy periods, let's look at the next table here. So on this table, and on this is data from several studies, depending on the specific deficiency or the specific disorder, look at how high the prevalence can be. So that means that, for example, on those with factor 7 deficiency, 50 out of 100 women are definitely gonna have issues with prolonged or heavy periods. And look at the range with GT patients. Like some studies actually even report that almost 100 out of 100 women are gonna be suffering or gonna be presenting heavy periods. So that's important, because we don't need just to say, okay, so I have a heavy period and not think about bleeding disorders, right? And that goes in general. And that's always a discussion that I have with my gynecologist colleagues here in Miami, because we tend to believe that if a woman presents with heavy periods, that she doesn't deserve or doesn't need investigation for a bleeding disorder. And now we know that that is actually not true, because we know that close to 30% of women who present with heavy periods are gonna be diagnosed at the end with a bleeding disorder. And most of the times, it's actually one of the rare bleeding disorders that is the cause of their heavy periods. On the same study that I presented to you earlier, in where we saw the 2020 data for women with bleeding disorders, looking here, the prevalence, and probably it's too small for you to look at, but look, this is heavy menstrual period, this is postpartum bleeding, and this here is joint bleeding. So look at how high the percentages can be, and especially pay attention to here. So this is just the prevalence of joint bleeds in women with actually any bleeding problem. But those with rare disorders have a prevalence that is actually close to 15%. So we also need to pay attention to that, and remember that this joint bleed doesn't necessarily need to be evident. So it doesn't necessarily need to be like, the pictures that we all see of kids with hemophilia, and they present with swollen big joints, knees, elbows, etc. We are now leaning towards, and I'm going to show it later too, to the concept of microbleeds affecting women with bleeding disorders as well. Microbleeds means that you're not necessarily going to see the bleed happening, but as the bleeds continue happening year after year or time after time, there's going to be a point or a breaking point in where the joints are already going to be affected. And then that's when we start presenting, joint pains, joint aches, etc. And that's because, we haven't really been able to identify those mini bleeds or small bleeds on time, and more importantly, providing the right treatment. Another important factor with women, or for women with rare bleeding disorders or bleeding disorders in general, is the fact that anemia is definitely highly prevalent in our population, right? So we just don't need to fight, or we just don't need to kind of like pay attention or address the bleeding problem or the bleeding symptoms. We also need to pay attention to anemia, and most of the time this is iron deficiency anemia. So look at, for example, this study that investigated the prevalence of anemia in patients in women with factor 7 deficiency and heavy periods. Almost 50% of these women with factor 7 had anemia. And that's also important to understand and important to identify, so we will treat and we will, control the anemia on a timely manner and on an appropriate manner, because we know that anemia can affect many other different organs and systems in our bodies that is important to address. This is the study that I was talking to and telling you about, and it's a shame that, again, thanks to our friend COVID, we weren't able to continue doing that this year. This is the study for those of you that were present last year. We're hoping, John, to continue doing this next year. But this is our WAP study. So our WAP study, we actually are investigating exactly this. What is the prevalence of joint disease, so abnormal joints, in women with rare bleeding disorders or with all bleeding disorders in general? So this is something we did last year in New Mexico, and we were able to enroll up to 13 women from 18 to 50 years of age diagnosed with a bleeding disorder, right? So here we have the majority of them being hemophilia A or B carriers or mild hemophilia. There were 3 factor 7 deficiency patients and 1 with severe von Willebrand disease. But what is interesting is, number 1, and we need to do better on this, okay? So look, almost 85% of the population of women with bleeding disorder is overweight. And actually 61% of patients are actually obese. So that certainly doesn't help with our joint health, right? So the more pressure, the more, the more we put our joints, especially ankles, especially knees, to work to support their weight, the earlier or the easier that's gonna be for them to suffer. So that's certainly something that is very striking to me. And what we see here, when I say significant correlation between the BMI, so overweight and obesity, with this score, the HJHS score. So this is a score that we usually, most of the times, use in everybody with a bleeding disorder to actually test or evaluate how healthy our joints are, okay? How good our joint function is. And as we see here, so the more overweight or obese we are down here, the more that our joints are suffering and the more that our joints would suffer. And actually we correlated this with this ultrasound score. So what we do is we ultrasound the knee, we ultrasound the elbow, and we ultrasound the ankle, and kind of like we try to identify changes happening there. Changes that are not just to be considered proper of, typical of age, but more so consistent with the bleeding disorder. And so this is what is striking. So like, I think that that's also something that is really underreported, but something that we really need to pay attention to. So, joints also are a big component and a big player of every woman that has a rare bleeding disorder or has a bleeding disorder in general. Okay, so as I said, for those of you that were not able to participate last year, I hope really that you'll join us next year and that we'll be able to be together. And then if you're interested in participating in this study, just, keep your heads up and we'll hopefully be able to see how your joints are doing. But this is great, and this is good data that as we continue capturing more women, I think that the more interesting that's going to be. So let's talk about the significance of having an RBD during pregnancy, delivery, and the postpartum period. Overall, there is a higher risk of obstetric complications reported in women with RBDs. For example, as we see here, miscarriages that are going to result either on fetal loss or preterm delivery are very quite common, especially in those women with fibrinogen or factor 13 deficiencies. Okay? And what it makes it tricky during delivery and especially also during pregnancy is that some of these factors are going to increase as the pregnancy progresses and moves, close to the, 40 weeks, 38 weeks, whatever. But soon after the delivery is completed, then these factors are going to go and drop back down to basal. And this is when the problem of postpartum hemorrhage or postpartum bleeding comes to be a real problem for us. This study, again, recently published in 2020. So I don't know if you have noticed, but a lot of this data is actually really new and has been published actually just, a few months ago. So postpartum hemorrhage, we know, is the main cause of maternal morbidity and mortality all over the world, right? 25% of maternal deaths are because there is, really uncontrollable bleeding after the delivery. So what these investigators did is they analyzed 120 women with history of heavy bleeding after delivery, and that they actually even required to get admitted to the ICU. And what it was actually really interesting is that a specific bleeding disorder was diagnosed in 69 of these women. So actually more than half of these women had a bleeding disorder. Again, it was not identified up until that point. So nobody knew that these women going into not just pregnancy, but delivery, etc., had a bleeding disorder. And, as we can see, because of just lack of knowledge, these women end up in the ICU. Important as well to consider, looking here, so 9% of these 69 women have what it's still considered a rare bleeding disorder, either fibrinogen problems, factor 7, factor 11, factor 10. Okay? And my overall message of this is that an appropriate and timely diagnosis before pregnancy, especially in those women with bleeding history, it's importantly and extremely effective in preventing PPH or postpartum hemorrhage. And that's something that, we as hematologists and you guys as part of our community, we really need to spread the word out. We really need to spread the word out that when a woman presents with abnormal bleeding, like heavy periods, easy bruising, etc., there has to be, or there must be, an evaluation to rule out a bleeding disorder. Now, this evaluation is not always easy to make or easy to do, because as you see here in this little flow, right? So like look at the different several steps that sometimes are needed to identify a rare bleeding disorder or a bleeding disorder in general. So we first, most importantly, when everything needs to start from either the primary care provider or actually from the patient herself, to really say, okay, there is something that is not normal. There is something that, I probably should be evaluated. And then, of course, raising awareness of this is going to, eventually translate into these women being referred to not just a hematologist, but a hematologist with experience in bleeding disorders, because that's also important when it comes to rare bleeding disorders. You need to go where, people it's not that they don't know what they're doing, but people with experience in rare bleeding disorders to actually get to the right diagnosis. I think I shared that with you. I shared with you last year, but you have no idea how many times. And I heard that we're gonna talk about heavy periods and contraception on in a month from now. But it's actually very interesting the percentage of young adolescents that come and they think that they have a normal period when they don't. And that's just because it's still a taboo, something that is not really, discussed in family, or not something that is not discussed among friends. But many times I go to my office and I say like, okay, so you have heavy periods, and most of the times the answer is no, my periods are fine. And then I start saying, okay, how many days your period lasts? And then they say like, oh, it lasts 14 days, and I'm like, okay, and is that normal? And they're like, yeah, I mean, that's normal. And it's like, okay, but I don't understand why. And they say like, well, because first of all, I mean, I don't know how other periods are, because I don't talk that to my school friends or to my friends at the yoga class. But also because my mom and my grandma and my auntie and everybody also have periods for 14 days. To me, that it's quite normal. So you understand the importance of really saying what is normal, what is not normal, and kind of like just have to be able to speak up and to say like, okay, so there's something, right? Because once we identify, or the patient, the woman identify that there is something not quite okay, then we're able to kind of like start this very complex way. And my purpose with this slide here is, of course, not for us to all be, to graduate from, the coagulation world, but just for you all to see how many steps it takes up until we're finally able to diagnose a rare bleeding disorder, right? So look in here, because even like at the beginning of the workup, so we tend to say, okay, so it has to be BWD. I mean, it must be BWD because that's the most common, whatever. But it's not always the case. And we need to be patient, and we need to have some experience to actually be able to really put together the dots and say, okay, so it's not this, it's not that. So maybe it's a factor 7. So maybe it's a factor 2. Maybe it's a platelet disorder. So that is what it's important, and this just requires really experience. And again, even with experience, sometimes it's just never easy. It's just very it's very interesting how much time sometimes we invest up until we finally find the diagnosis. But that's the important piece of it, right? So up until we know what the problem is, we'll know how to fix the problem. So just for thought. Some other challenges that we all face is that there are really lack of a standardization for factor tests. Sometimes, like if you go to one lab versus the other, if you get your lab on at this place versus the other, so each of them have their own levels of normal, and there cannot be the same for everybody. So that's also something important to consider. It's also important to consider, and I mentioned this already, that not because we necessarily have a normal level at some point in our lives, because some of our coagulation factors, they tend to increase as we get older, okay? So, we are 5 years of age, and our factor, let's pick up, like factor, whatever, 7 is 40. And then we do the same exact test when we are 20, and my factor level is already 65. So it's already within normal. Does that mean that I don't have factor 7 anymore? No, this just means that, it's following up the trend. But then, as I said, when you really need to have a burst of your factor 7 or burst of your 11 or your burst of your fibrinogen, then that is when problems are going to come. Another factor to take into consideration is sometimes it's difficult to really get an accurate sample because, somebody is just a hard stick. The sample can be contaminated. So even when you have symptoms, you get yourself a lab done and the lab comes back normal. I mean, it's always important to repeat, especially if we don't really have an explanation for the symptoms that our patients are presenting. And this is the reason for why I showed you this slide right here, in where like the investigators on this one, you know, performed platelet studies in women with unexplained menorrhagia. Okay, so these women had, and they were 70 plus of them. They have heavy periods, but again, they did factor 7, 11. They tested for Glanzmann, they tested for, and everything came back normal or negative. But when they further went into explore for more platelet functional defects, for example, here like that, look at how many of them were actually low. So we're actually having a platelet problem in comparison to controls, right? In comparison to those without any problem. So this study, I think, emphasizes the importance of just not having a generic hemostatic or like bleeding disorder test, but that the test needs to be really very comprehensive. The testing process needs to be really comprehensive and should include platelet function testing. And sometimes actually what we do is we need to repeat the testing at least twice or at least 3 times to really finally being able to say, okay, there is actually no problem. And, you know, but even then, sometimes here in my clinic as well, even if I don't identify a problem, but I can somehow control or manage, for example, heavy periods, that's the most common problem in women. I do use some hemostatic therapies to help, because you know, you probably understand. I mean, I'm not the most experienced talking on this, but it's very frustrating when you have heavy periods and you don't know and you don't have an idea why you have a heavy period and why you bleed for 10 days and you need to change your pads every hour or so, because if not, you overflow or whatever. So like, it's important and something that we don't need to neglect, and we don't need to really say or pretend that there is no problems. When it comes to treatment is difficult, okay? So treatment for RBD patients is just difficult because many times there is not enough information into how we can properly address a specific problems, we can properly address a dental extraction, how we can properly address, oh, that my gallbladder is gonna needs to be taken out in a month. You know, how do we manage that? So like, you know, that's one problem. But the second important problem in RBDs is that even though, you know, for the other deficiencies, the more common deficiencies, hemophilia A, hemophilia B, BWD, we do have a specific coagulation factors to be used at therapies. For some of our rare factor deficiencies, we don't. And we just need to use what is available outside in order to try to control or try to manage these problems. We have to use FFP sometimes. In case of platelet dysfunction, we need to use platelet transfusions. In the case of factor 11, for example, there is no factor 11 concentrate available here in the US, so we need to use plasma, we need to do something. So like that is just a real problem. We need to know what our strategy is gonna be. And sometimes that's tricky when it comes to RBDs, because not all factors need the same amount of, or the same level to control a bleeding, or to have it on board in order to prevent any bleeding during surgery. So we also need to pay attention to this. And what I mean by that is that, look at here. So all factors are different one to another, right? So like they have different half-lives. So like that means like how much time when I infuse factor 7, for example, for how much time is gonna be good enough. And look at the difference, like fibrinogen, 7, 13, it's good enough for 14 days, whereas 7 is only good for 4 hours. So like we really need to have experience. With GT patients or with platelet deficient patients, as I said, I mean, one option is, yes, for sure, platelet transfusions, like, you know, I can give you good platelets, but, you know, that also comes with the risk for transfusion reactions, for you just stop responding to platelets the right way, so it makes it tricky. And I just hear as well, the amount of levels that I need are different from one factor to another. I mean, like, we really need to know what is good and how much is good, depending on the RBD that I have in front. And this is just another table that what the main idea here is that, as you see here, like, you know, there are really, for example, let's pay attention again to factor 11. Even here it says factor 11 concentrate. But as I just said, in the US, we don't have factor 11 concentrate to use. Factor 11 concentrate, we only found those in the UK and France, and just because they have a high incidence of that. But in the US, we need to use plasma, we need to use tranexamic acid. So we need to use other strategies to kind of like try to help our patients. And look at this study that was, again, published in 2020. So I have here patients with GT. I have here patients with 7, right? So look at the different options for treatment we have. So it's just not one size fits all. It's not that, you know, if I have factor 7, I only gonna need factor 7 and my problem is solved. No. I mean, I'm gonna need antifibrinolytics. I'm gonna need other sort of treatments. And with GT and platelet disorders in general, again, aside from transfusions, we don't have anything more specific to it, right? So we need to use, you know, recombinant factor 7 as an alternative. We need to use antifibrinolytics. So again, the options are limited and are not specific. So that's actually a very important piece of information too. Women with RBDs. Most importantly, we need, especially those when it comes to pregnancy and even the non-pregnancy state. So they just don't need to be monitored closely, but actually their management or their treatment has to be sort of like a multi-specialty type of treatment. So it's just not the PCP, or just not the gynecologist or the hematologist. So like it has to be a team effort to actually be able to increase the quality of life for you all, right? So and that's important for you all to keep in mind as well. So you really need to be having a multidisciplinary type of approach, depending on your problem, depending on your symptoms, of course, in order to get the best outcomes, the best results. So that it's all actually also very important to consider. Management of heavy periods. I mean, I have RBD specific treatments and I have recombinant products, platelet transfusions in the case of platelet issues. But, you know, there are other strategies as well. And, you know, I'm glad that we are going to have again this year our talk with the gynecologist, because, you know, there are different options. And what it has to be clear, at least to me, is that if a woman with a bleeding disorder, RBD especially, has a problem with her period, I mean, it's just not enough to say, okay, so, you know, we'll do our best, but we're not really going to be able to fully help. I mean, that has to change too. So we really, I mean, we have options, right? So we have, yes, some of them are more invasive than others, but our goal should be, or needs to be able to control the problem and to actually being able to make you all have a life normal as much as possible, or as close to normal or as a woman without a bleeding disorder. So that is actually very important to consider. Some medications that we need to avoid. Midol is top one. I mean, like we find this over the counter all the time, but you know, we don't realize that it has aspirin. So if we have a platelet disorder, if we have a coagulation factor problem, so that is certainly not going to help. Also very important, natural vitamins or supplements. So like high doses of omega-3 can also interfere with a proper coagulation process. So that's something that we also need to take into account. Of course, it goes without saying, Motrin, naproxen, that's a no-no. And prolonged use of antibiotics as well might be a risk factor, because some of them might actually cause microbleeds into, you know, because we develop gastritis, we develop whatever, just by taking a lot of antibiotics. So like those things that we not necessarily would think of them about them all the time, those need to be accounted. I mean, antidepressants as well for those with platelet disorders, that might also affect the ability of platelets to function the right way. And look into here about the psychosocial impact of having an RBD, right? So on this case, and it applies because there were two similar studies, one for factor 7 as this one, and then one for GT. And the aim of the study was to identify the burden of having a rare bleeding disorder. So look into these graphs. Even though that most of the RBD patients acknowledge that family, friends, or significant others are very supportive, so like this means satisfied, we have still to do a lot when it comes to employer and when it comes to a school support for, you know, those small kids that go to school, because most of them reported that, for example, as we see here, 16% reported losing or resigning from the job in adulthood as a direct result of their disease. And 29 of caregivers and 10% partners had also experienced issues with employment. And 30% of patients reported missing school days as children because of having bleeding problems and not necessarily being diagnosed on time, but more importantly, not necessarily being identified or treated or, you know, approached the right way. So I think that that's also something that we need to work and do more. Just to finish up really quick, I mean, what some things that we can do, or something that is I really should encourage you to do this 2020 is Athens recently has launched this Athens 10 study, which is, you know, it's called leveraging the Athens data set to document the state of rare coagulation disorders in the US. So it's really cool a study because we actually, it's something that we were talking about, right? So what this study offers as a benefit is that it sends genetic studies to actually really truly try to identify the exact mutation that is causing your GT, your renosolate, your fibrinogen problem, your 7 deficiency, and you can use that information in the future for genetic purposes, for genetic counseling, but also because it's good for all of us to know really what our problem is. As you remember, I said that, for example, for 7, most of the centers only can test for the most common deficiency, but not for like the, you know, more than 20, more than 30 mutations that are out there. So I really want to encourage you, like, depending on, I don't know if you're, but it'll be worth asking if your HTC is participating on this study, because it's something that's very cool. It's something that, especially for these disorders, GT, 7, 13, fibrinogen, we expect to enroll patients up until, you know, February, and then maybe the study is going to be on hold for some time. Maybe it's going to be closed. So, you know, if you have the ability to ask for this, I mean, please go ahead and do it. And there is this, and I don't know if you all are familiar with this website, rarecoagulationdisorders.org. That's actually a very great source of information. It has what they call the resource room that provide really current and searchable information, not just about what our disorder is, but this is the most important. It has really a nice database divided by the specific disorder when it comes to clinical trials and research initiatives around the world. So, like, you know, what's happening in Europe, or what's happening in Asia with factor 7 patients, with factor 13 patients. So, like, that's something that, you know, they update. My understanding is from time to time is a collaboration in between the Indiana HTC and the global registry of patients with rare bleeding disorders. So it's really nice, and you know, I myself didn't know about this. That's why I brought up this today. But it's something that, you know, you explore. And then they tell you how to explain to others what your specific problem or disorder is, etc., etc. So it's really, really cool and nice. As a conclusion, just to finish up, so RBDs can seriously impact women's quality of life, right? That's basically out front. It has effects on the academic, professional, and social lives. Long-lasting heavy menstrual periods is associated with iron deficiency anemia, and that's important to take into account because it has a lot of consequences. Medical care for women with bleeding disorders in general is still lacking, especially for those with rare bleeding disorders, as there still are taboos or obstacles preventing women from not just seeking help, but also to really identify as having a problem, and that is important. Caregivers are often unaware about bleeding disorders in women, and that is not just caregivers. There's a lot outside, physicians, nurses, everybody that really doesn't realize that women cannot just have a bleeding disorder, but they can actually have a severe bleeding disorder. And so for that reason, the diagnosis is sometimes neglected, and the appropriate treatment is not necessarily all the times provided. So, we still have to do more on that. That is my last slide for this presentation. I just want to show you this case that for some of you might be familiar. But I always like to bring it up because I always get surprise faces. This is an adolescent that came to my clinic, 13-year-old, as you see. We are in Miami, so he was Hispanic, with no other history, right? So, look here, periods to start at age 12, periods were 4 days in length, so no heavy, every 21 and 28 days, or regular, no heavy flow, no anemia, no medications, no family history of any bleeding disorders. But what was interesting on this girl was that she presented these symptoms here, as we see here. So, like, every time that the woman had, that this girl, like another woman that had a period, she was having this blood coming down from her eyes, blood coming out from her belly button, and even from her ears. And the bleeding was painless. It was associated with her periods. And again, we did the most comprehensive bleeding disorder workup that we could, that we were able to. And we didn't identify a source, but we continue nagging and continue investigating. And up until finally we were able to come up with a reason for why. And the reason why, what we call vicarious menstruation, which is not a bleeding disorder per se necessarily, but the C here is when there is bleeding from other mucous membranes out from the uterine cavity. So, and that occurs at the time of menstruation. So it's basically uterine tissue that, it's on our eyes, is on our belly button, and that is why the cycles were associated with their symptoms. But again, the purpose for me bringing up this is that we just need to further investigate and try to really get to the bottom of it, to be able to offer the right treatment. In the case of this girl, we treated her with OCPs, and so we just stopped her periods. And she was happy. She was like, she never had this problem at all anymore, and she was able to go, because imagine, I mean, she wasn't able to go to school, she wasn't able to play with friends, etc., because every 28 days she presented this. So again, we really need to try to get to the bottom of it. This is my last slide, and I now want to thank you all. I want to thank Chess, Inspiration, LadyBugs, for the opportunity. I always enjoy coming every year to give these rare bleeding disorders. And again, I'm happy because each year I think that there is more information outside. And yeah, I mean, I don't think that we should be calling rare bleeding disorders anymore. I mean, we should call them bleeding disorders as a whole. And there are different types of bleeding disorders, yes, but they all deserve attention, and they all deserve the right treatment and the appropriate investigations. So thank you all for your attention.
Thank you so much, Fernando. Could you answer a couple of questions?
Of course, yes.
Okay, so one of the ones that came up twice, I'm going to ask is, do you think there's, and if anyone wants to speak up because I don't ask it correctly, is there a connection between joint bleeds, or does it have an effect on tarsal tunnel or carpal tunnel?
That's a question that I get a lot, and the right answer is I don't know, and we don't know because we haven't investigated that. There are some factor deficiencies that might be associated with collagen, because again, we have talked about factor deficiencies and platelet disorders, but some of them also involve or affect the collagen itself as well. So that might also be the reason for why we present, these problems with, small joints and the small issues like rheumatological issues like such as carpal tunnel, for example. But as far as I know, there is no, clear connection in between one to the other, but definitely is certainly something that we should investigate and find out more.
Okay. Is this your family?
That is my family. Are you watching my family? Yes,
They're
those
beautiful.
are my twins, Gabi.
Thank you for sharing.
This is Gabi, this is Rafi, and she's my wife right here.
Oh my goodness, beautiful. Thank you.
Thank you.
Okay, so Shannon had a question.
Yes.
Shannon, are you still with us? Her husband doesn't have any factor 7 mutations. How is he a carrier?
He doesn't have an identified mutation, right?
No, he was part of the genetic testing. And I believe they said there was over 103 families that were tested, and only 3 people had no mutations. One was my husband, and one was my daughter. There's no factor 7 mutations whatsoever on any of his 7 genes.
And how low are their 7s? I mean, their levels, are they low?
Perfectly normal at 1,500.
So to have normal factor 7 levels and no mutation.
Correct.
So and why is it that they were tested then? I don't quite.
Because myself and my son are severe factor 7.
So yourself and your son, okay. So if we go, so what I will then assume and conclude is that definitely, yes, your husband does not have any factor 7, and then the mutation that is causing your severe factor 7 deficiency is just one of them, like, because I said that the majority of them are autosomal recessive, right? But there are some mutations that actually can be just independent, or like actually can be autosomal dominant. So meaning that you don't need to have like the 50% from mom, 50% from that to really have the deficiency. You might just have like 50%, and that only gene is enough to actually cause a severe mutation. So, and remember that, I don't know when the testing exactly was done, but I'm pretty sure that there are more and more new mutations that we still don't know of. So it'll be interesting, but yeah. So I think that that's what happened in your case. It's the same case that it happens, and it's been described a lot in hemophilia, for example. That all of a sudden, a kid is diagnosed with hemophilia, but there is no history whatsoever, and the dad, the grandfather, the mother, uncles, they are all perfectly fine. So they might also be what they're called de novo mutations, like the mutations that they just happened out of blue. And they tend to behave as dominant. So like, just having the 50% is enough for causing a severe mutation. A severe deficiency, sorry.
Thank you.
Thank you so much. One of the other questions was, what antibiotics should be avoided?
So it's not actually a specific antibiotics. What the actual recommendation is to avoid prolonged use of antibiotics, right? And this also come with those antibiotics that if we take for a long time, I said, might cause microbleeding in the gut and gastritis type of thing. But there are also some other antibiotics that might affect the liver function, right? And if they affect the liver function, what happens is that as a lot of our coagulation factors are made up in the liver. So think about it. So if we have already a factor 7 deficiency, we know that factor 7 is also made up in the liver. So if we kind of like, upset the liver a little bit, then, from what we do, we're going to actually do less than that, right? Because the liver is upset. It's not going to make the 30%, the 20%, whatever it is. So it's more so that it has to be with that. It's not that just an antibiotic has to be avoided. It's just the prolonged use of antibiotics, that problem.
Gotcha. And I'm going to try to get one more in, if you don't mind, Fernando.
I do not at all.
Okay, we have a new person with us this evening. I don't know if it's Chantal or Natalie, but one of them, both of them. Hi. They wanted.
It's both of us. We're both factor 7 deficient, and my son too.
Hi there.
Hi there.
And did you want to know why do half-lives vary for different disorders? I think that was your question, right? Oh, you're muted.
But I saw them saying yes. So what happens is that it's just the natural way coagulation factors are. So from all the coagulation factors, factor 7 is the one that lasts the less amount of time in our system. It's just the way it is. So that's why it's important, for example, when we received factor 7 concentrate, that we need to get the factor 7 concentrate every so often, every 4 to 6 hours, because that's the way it's metabolized. It's the way it goes, kicks in, and then our own system will start metabolizing and eliminating that, right? So each protein, because at the end, all coagulation factors are proteins that are flowing in our vessels, right? So each of them are eliminated as its own piece and as its own speed. So it's just kind of characteristic of each and every single of the coagulation factors. So that's why we have factors that are only 4 hours, and we have on the other end factor 13 that lasts 11, 14 days. That's also important to consider for those patients needing prophylaxis, right? Because believe it or not, RBD patients and RBD girls, sometimes they do need prophylaxis. Prophylaxis meaning that they need constant supply of a factor concentrate. It's important because then that allows us as well to kind of decide the appropriate regimen, the appropriate timing in where how I need to give that factor to my patient. For factor 7 patients, again, as I said, I need to if they go to surgery, if they have a wisdom tooth extraction and they need to go to surgery, I need to supplement every 4 hours or every 6 hours for a whole day. Whereas if that same surgery happened on a factor 13 patient, one dose prior to the surgery, that might be good enough, and I don't need to do anymore. So that it's just a characteristic of each of the factors, but it's important to have it and keep it in mind, so that way we can treat the right way.
Okay, thank you again. And then Dina, I know you had a couple of questions. You have one that you'd would like to ask real quickly? Dina? Oh, you're muted.
I was muted. So I think that, there's a little theory that I have.
Mm-hmm.
So when you talk about consanguinity, and I have been told by a few medical professionals that the consanguinity has something to do with factor 7. But my parents are 10th cousins.
They're cousins, okay.
They're 10th cousins.
Oh, 10th cousins, okay.
And we are Mayflower descendants, but so my 11th great grandfather is my 11th great grandfather through my mother and my father.
Okay.
And with the Mayflower population being that of 60, you can see where there would be some consanguinity.
Right.
Do you think it would be passed down through that many generations to where both my parents could carry it? Yes?
Yeah, it might be, because that what is a typical example of that is factor 11, because factor 11 is so prevalent in the Ashkenazi Jewish population. So oftentimes here in Miami, we ask, okay, so do you have any Jewish ancestry, right? Or and people comes from Mexico, and they're like, okay, so not Jewish, but then and we kind of dig in, and then 2 months after they email us or they call us, and they are like, oh yeah, you know what, I now ask my great auntie that's still alive, and she said that my great grandfather used to be, or just comes from Eastern Europe, and we have some roots that are Ashkenazi, so okay, so that's why. And again, what happens also is that not this, especially the RBDs, are not necessarily diagnosed in every single generation, but it doesn't necessarily mean that it was not there. right? So like, it's just that, you know, for whatever reason, because some of the patients are going to be asymptomatic. And if you're lucky enough and you never needed a surgery, you never needed nothing, like, you really can tell. But yeah, specifically answering to your question, 11th generation, 12th generation, genes are genes. They come down at the end.
And I have cousins that are on this that I found through this process. We never knew we were related. So it's really interesting.
It is. It's very interesting. I mean, genetics are always really cool to track down.
Thank you again, Fernando. You're amazing.
No, my pleasure. So, like, please, I hope that you like it. I hope that you learned some, because I did, especially this year. You know, it's always good to learn, and you always learn. So it was a pleasure to be here. Thanks for the invite.
Great to have you. Good night, everybody. We'll see you next week, we hope. Mwah.
Keep enjoying. Bye-bye.